Hello everyone. Today we are going to discuss head injury. So let's start the head injury with what are the types and then what is the pathophysiology. So in the types we can see in the head injury are dividing into two types, primary and secondary. We divide the head injury into primary types and secondary. So secondary is caused by infections whenever there is hypoxia or there is increased intracranial pressure or there is hypoperfusion, then it can cause secondary head injury. Primary is, again we divide into focal and diffuse. So focal you can have sharp injuries, penetrating injury, and then can have blunt injury, cope or center cope injury. Sorry, not center cope, it's conter cope injury. And diffuse is again contusions and diffuse axonal injury. Diffuse axonal injury. Diffuse axonal injury. So let me emphasize on few important things here. So what is cope and conter cope? So if we imagine that now so the brain is inside the skull. It is inside the thick cranium. Okay, so it's inside the thick cranium. Okay? There's the brain inside the thick cranium, which is covered by a little bit of cerebrospinal fluid. So if there is a direct blow here, if there is a direct blow on the head, on the frontal part, yes, we can understand there will be bruising here, there will be a damage to the brain here. So when there is a damage to the brain there, then we call it a cope injury. And when there is a heavy impact, then this brain, there is a acceleration and deacceleration. It moves inside the cranium. Whatever the space is available, it will move. So when it will move, and it will strike the back part of the cranium, then it can also have injury here. So when the impact is here and injury is here, we call it a when the injury is at the back because it's shaking, then it's called conter cope. It's called conter cope. Okay, so it's not necessary that only the person can have cope injury. It can have also conter cope, which is at the back side because of the shaking. It's going back when there's a heavy impact here. The brain moves and going back, and it is hitting the base of the skull, and this part is also might damage. So that's a conter cope injury. Then next important thing you should know before starting the pathophysiology, the diffuse axonal injury. So let's say, so this is the brain stem here, this is the brain stem, and we know in the brain stem there is pons and medulla. So what is there in the brain stem? We have the reticular formation, which maintains our alertness. So here there is the reticular formation which alerts the brain. It gives signal and it may keep us awake. So these signals come from where? It comes from the reticular activating system or the reticular formation, okay, which is at the brain stem. Now this part is, the brain stem is fixed. This part is fixed. Okay, this part is fixed. So when the brain moves, when the brain moves, these are the axons. These are the axons which are giving signal to the brain and keeping the brain alert. They are not fixed. Only the fixed part is this reticular formation in the brain stem. So this part is fixed. So when there is an impact, so this brain moves along with these axons. So these axons can be also teared. These axons can be also teared or can have impactness. As a result, which we call can be loss of consciousness. There can be loss of consciousness. This part is fixed. So when brain is moving, you can see these are axons which are going to different levels of the brain, and it is also moving with the brain. So there may be cope injury, there may be conter cope, and there may be a diffuse axonal injury. because of tearing or shearing of the axons coming out of it, which also moves with the brain. So that is the reason there can be loss of consciousness, because the alertness is generated from here, from the reticular formation, which is activating the rest of the part of the brain and keeping us alert. So when there is any problem in these axons, then it may reduce the alertness or the awakening of the brain. So that is why there is loss of consciousness. Alright, so now we go to the pathophysiology. So what is the pathophysiology? So next we will try to understand pathophysiology of head injury. To understand the pathophysiology, you must know the basics of physiology regarding the cerebral blood flow. Okay. So let's try to understand what is cerebral blood flow and autoregulation. Cerebral blood flow and autoregulation. Now what happens? The blood supply to the brain is at a constant. It is always maintained at a 50 to 55 ml per 100 gram per minute to the brain. It is maintained at this. So means in 1 minute, in 100 gram of tissue, the brain receives around 55 ml. So overall the brain tissue, receives around 750 ml per minute, which is around 20% of the cardiac output. So when it is from the left ventricle, when it comes out of the cardiac output, okay, so some amount of blood that goes to the brain, that is 20%, 15 to 20%. So every time there is a cardiac output, 15 to 20% goes to the brain. 15 to 20% goes to the brain. So that is in 1 minute is 55 ml to 100 gram. So every 100 gram receives 55 ml here in 1 minute. Now this is maintained so that the brain don't deprive of any oxygen or any blood flow during any sort of emergencies. Okay, up to a certain limit. Now let's say there is an increase in blood pressure, increase in systemic blood pressure. Let's say the person's systemic blood pressure has increased to 160 systolic to 140 millimeter of blood pressure of Hg. So what will happen when the systemic blood pressure is increased? So when the blood pressure is increased, we know the pressure is increased, there will be increased blood flow. There will be increased blood flow. There will be increased blood flow to rest of the organs. But it is not same in the case of the brain. So though there is an increase in blood flow in the systemic circulation, but the brain will maintain by vasoconstriction or by vasodilatation, it will maintain. So if the blood vessel is this, so with increasing blood pressure, the blood may be increased flow. There may be increased cerebral blood flow, increased cerebral flow. But this is not there by maintaining. So when the increased blood pressure is there in the body, so increased blood pressure, which will lead to increased blood flow. But what happens in brain? When this blood enters the brain, what happens? Most of the vessels, they are vasoconstricted. So as a vasoconstriction, it is only 55 ml of blood is reaching the brain. So this is the autoregulation that brain always maintains, irrespective of the change in the blood pressure, up in 55 ml. So whenever the pressure decrease in the rest of the part of the body and there is decreased blood flow, then the blood vessel will vasodilate so that more blood can come. And when the pressure increase in the rest of the part of the body, so the brain don't receive more than needed blood, there will be vasoconstriction. So less amount of blood will come. So it is always maintained at this magic figure of 55 ml per 100 gram. Okay. So let me explain in more details here. So what happens here? So this is the mean arterial pressure, this side, and this is the blood volume. So 55. So let's say this is 55 and this is 100 ml. So let's say this is 50 mean arterial pressure and 100, 150. So what is the mean arterial pressure? That is the mean arterial pressure. That is the average pressure in the blood vessel. And how will you measure it? We measure the mean arterial pressure as diastolic pressure plus then systolic pressure minus diastolic pressure divided by 3. So if the normal blood pressure is 120 by 80, then mean arterial pressure will be, diastolic pressure is 80 plus, what is the difference? That is the pulse pressure. What is the difference? 120 minus 80, that will be 40 divided by 3. So around we can say 90 something. So 93, it will come at 93. So normal mean arterial pressure is around 90 to 100 like that. Okay. So what happens in that mean arterial pressure? There is blood flow is maintained at a 55 ml per minute. Okay. So at 100 we get here. When there is 100, we get the blood flow as 55. That's normal. So the brain, it maintains the same amount of blood flow when there is a change from 50 to 100. Look, the pressure is increasing, but still the blood flow is at constant level at 55 ml. Okay. But if when the pressure decreases more, then there is hypoperfusion, blood volume also decrease, and when the pressure increase more than that, the brain cannot auto-regulate anymore, and then there is increased blood flow. So when the pressure more, then it cannot accommodate, it cannot do any sort of auto-regulation. So blood flow will increase. So the curve looks like this. So this part is the brain auto-regulation. This part is the brain auto-regulation. So auto-regulation occurs between 55 to 150. That is the mean arterial pressure. Okay. So in between the 50 to 150, the brain maintains the same amount of blood reaching to the brain. Means whether the blood pressure when it changes from 100 to 120, 140, so at that time also the brain will receive 55 ml. So how it do? It do by vasoconstriction and vasodilatation according to the increase or decrease in blood pressure. So when more blood is about to come because of increased blood pressure, it will vasoconstrict. All the vessels in the brain will go vasoconstriction. And when there is less blood pressure is there, and less blood is about to reach brain, so brain vessels will vasodilate so that more blood can come. So that is by vasoconstriction and vasodilator, it maintains a constant flow of blood, 55 ml per minute. That is autoregulation. So that is autoregulation. So in this way, brain auto-regulates. But whenever there is head injury, this whole process is disturbed. The whole process of the auto-regulation is disturbed. Whenever there is head injury, means whenever there is any tissue damage, there is any traumatic brain injury, right? So that is about auto-regulation. Now coming to the intracranial pressure. Or ICP. So brain is covered by the skull, and inside the brain we have blood vessels. So what is intracranial pressure? The intracranial pressure is the pressure exerted here. The pressure exerted to the brain by the brain. It is the pressure. So if we increase the intracranial pressure, means it will push the brain, right, from every side. It will give compression. So what will happen to the blood vessels? The blood vessels will, so if there is intracranial pressure is increased, so when the intracranial pressure is increased, it will also compress the blood vessels, leading to vasoconstriction. So increased intracranial pressure will lead to compress the blood vessel, so that blood vessel become vasoconstriction. Okay, so when this is intracranial pressure. Now blood vessels cannot constrict because it has its own pressure. It will resist by its mean arterial pressure, which is flowing at 100. Okay, that's normal. We are just taking a normal number. The blood is flowing, so it will also resist. So every time the blood flows, it is flowing at 100, and the normal intracranial pressure is 10. Normal intracranial pressure is 10. So blood, because the pressure in the blood flow in the arteries is higher than this, so blood is about, that's why blood can reach the brain. That's why blood can perfuse the brain. Okay, which we call the cerebral perfusion pressure. So what is cerebral perfusion pressure? CPP. Now look, there is a pressure of 100. So here it's giving also a counter pressure of 100, and this is 10. So what is the pressure that is reaching here? Reaching here is 100 minus 10, 90. Means what I'm trying to say here, suppose you have to move from point A to point B. So every day you have to go from point A to point B, and you have to deliver $100. You have to go and take $100 for the person named B. So he has to get $100 every day so that he can survive. So when you move from here, from your workplace to his home, then at the road you have some toll stations, and you have to give some money to your debt. You have some earlier old debt that you have to repay those. So how much you are giving here? You are giving it, so let's say 10. You are giving 5 and 5 both sides, and you are giving 10. $10 you have to spend on the way. So how much he is receiving every time you are taking 100, and how much he is receiving? He is receiving $90. So this is mean arterial pressure. This is mean arterial pressure. This is intracranial pressure, and this is cerebral perfusion pressure. So how will you calculate cerebral perfusion pressure is, so how much he is receiving? How will you calculate that? When you get the mean arterial pressure minus intracranial pressure. That's how we calculate. Okay, that's how we calculate. Means cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. Minus intracranial pressure. Okay, so minus intracranial pressure means mean arterial pressure, let's say 100, minus normal intracranial pressure, let's say 10. So it is at a normal central cerebral perfusion pressure is maintained at 90. So let's say there is increased intracranial pressure. Okay, let's say there is increased intracranial pressure. So there is, now this is a skull, and there is some bleeding or hematoma, and there is increased intracranial pressure because of some space occupying lesions. So when there is increased intracranial pressure, as the intracranial pressure will go down, what will happen? As the intracranial pressure will go up because of some space occupying lesions, as the increased intracranial pressure will go up, what will happen? This will go down. Means if you have more debt on the road, if you are have to pay more debt, you have to pay some more loans on your way, he will receive less. So if you have to pay here around $20 on your way, then how much he will receive? 100 minus 20, that's coming to 80. So he is receiving less. So now he have to fight for his survival. He have to work hard because he is receiving less. So there is his quality of life will go down because he is receiving less money, because you are paying more on your way. You are paying whatever the loan or debt, you are paying more. The same way, as the intracranial pressure increase, say intracranial pressure from 10, it has become 30. So 100 minus 30, what will happen? 100 minus 30, so cerebral perfusion pressure is equal 70. So only 70 ml of blood is sorry, because the pressure is reduced to 70, so blood will reach the brain in a low amount. So when there is a reduced cerebral perfusion pressure, so there will be reduced blood flow. So decreased cerebral perfusion pressure, perfusion means how much blood is received. The decreased cerebral perfusion pressure will decrease the cerebral blood flow. Okay, so that's why intracranial pressure, maintenance of this intracranial pressure is very important. That's why the treatment of head injury is, first thing is that we have to down the intracranial pressure. Because when intracranial pressure will go high, cerebral perfusion pressure will go down. So as it will go down, there will be decreased blood coming to the brain. And brain will be going for hypoxic-like symptoms. There will be tissue damage more, and there can be necrosis. There can be what's called apoptosis, cell death, leading to scars. Many other things will come out because of this. This is the whole pathophysiology. Okay, to understand the pathophysiology head injury, this is the main thing. Apart from that, you have to also understand the Monroe-Kelly doctrine. So let's understand the Monroe-Kelly doctrine after this. So what is Monroe-Kelly doctrine? So according to this Monroe-Kelly doctrine, it has been said that the brain is in a closed box. It is a closed box theory, right? So that's a brain inside the skull, and what else in the brain? There is CSF. So this is a closed box. Okay, we can see our head is closed. It's a closed box. Inside it we have brain, we have some amount of CSF, and there is blood volume, and it's blood. Okay. So what is in this closed box? We have the brain here. So this is the brain. Then there is CSF. And then there is blood vessels here. Blood vessels which has blood. So which is blood. So here there is some blood are venous. So let's make it half. So these are venous blood, and these are arterial blood. Okay. So if we make a like this, so the brain occupies, out of this box, brain occupies around 1500 ml. So this is the brain. So it is around 1500 ml. It differs. Let's go for the number. Something it is 1400, you can say. So I just make it round figure, 1500 ml. So how much is the CSF present here? CSF is 150 ml. And how much is the blood present here? It's 75, that is 150. So 75 venous, 75 arterial. Okay. So this is a closed. We cannot accommodate. This is a fixed number. Means 1500. So what is the total volume inside this? Inside the skull, what is the total volume is there? So 1500 plus 150 plus 150. That is blood. So this is CSF. This is blood. And this is brain volume. So how much is that? It's around 1800. Okay. So it's around 1800 ml. Now according to Monroe-Kelly doctrine, the theory says that if any of these numbers change, then other numbers have to compensate, because there is no space here. Suppose blood volume has increased due to any reasons, there is increased blood volume. So if we increase the blood volume, okay, if we increase the blood volume, say from 150 we made it 200. So this is fixed, we cannot change this. So if this is made to 200, so we have to reduce 50 ml somewhere here, so that this number remains at fixed 1800. So let's say what will happen, if there is increased blood volume, the CSF will go down to 100 ml. CSF will go down to 100 ml, so that number remains same. Now let's say there is more blood volume. Okay, so this is just I'm telling a situation. Okay, let's try to understand in a different way now. So let's say there is a space occupying lesion. There is a bleeding here and it is taking a space here. It's making a space. It's taking its own space because there is an internal bleeding because of head injury and there is a blood collected here. So it is not supposed to be there. But now there is a space occupying lesion. SOL, soul. Space occupying lesion. Okay, let's see what will happen if there is a space occupying lesion. So we know that there is brain volume is 1500 ml. Okay, let's go to the right number. Let's make it 1400 ml plus 150 is CSF plus 150 is the blood. Okay, that makes 1800. Now we have got a space occupying lesion also. There is a space occupying lesion. Let's say the space occupying lesion is taking around 100 ml of space. Okay. Just for example, this space is around 100 ml. They are taking 100 ml of space. So what will happen? If there is 100 ml of space, extra space here is created. Now they have to compensate so that this number remains same. That is the Monroe-Kelly doctrine. So what will happen? When there is 100 ml of space is taken here, what will happen? First the brain will try to reduce the venous blood. So we know the blood will be venous blood 75 ml venous and 75 plus 75 ml arterial venous. So first to compensate that so that the intracranial pressure don't rise. Otherwise what will happen? This space occupying lesion will go on. So when it's becoming big, what will happen? It is giving intracranial pressure. So as a result there will be increased intracranial pressure. Now we know that if there is increased intracranial pressure, there will be decreased blood flow, because there is decreased cerebral perfusion pressure. So brain is trying to control this, that intracranial pressure don't increase by making this number fixed. Okay, so up to a certain limit brain is trying to do that, so that this number remain fixed, so that intracranial pressure don't increase, because if this number increase, then intracranial pressure is increasing. That means, so what is doing, so when the space occupying lesion, suppose for example, is taking 100 ml of space, now brain will try to compensate here so that the number remains fixed at 1800. So what is doing here? Here it is decreasing the venous blood first. So it decreasing the venous blood. So what is happening here? So this is the venous blood. So it's trying, whatever it is trying to let it go, vasodilatation. All the venous blood vessels are vasodilated. So more blood is going out. So more venous blood is going out, and so that some space is there, so that the brain can now accommodate some space for this extra guest. Okay, so first of all, what is happening? Decreased venous blood. Let's say that this space occupying lesion is now still growing. So what will happen in next phase? So let's say this space occupying lesion is becoming more and more big. So now it has to cut off this thing also. But it don't want to do that. It don't want to do that because it needs blood. It cannot compromise the arterial blood at the beginning. Okay. So what will happen? It will reduce the CSF flow. Now CSF production will be minimized. So now let's say this SOL has become 200 ml. So to make the number still constant 1800, it has to compromise with another 100 ml here. So it has to reduce the CSF, say from 150 to 50 ml. So that the number still remains same. That is Monroe-Kelly doctrine. That when one is affected, other two will compensate. Okay, so number remains fixed. So SOL is growing and now CSF has decreased. So next thing, after decreased venous blood flow, the CSF decrease. So still it has managed that intracranial pressure has still not raised. Because if there is intracranial pressure go on increasing, then there will be more hazards and more problem is coming up. So brain will try its own thing first. Okay, so first there is decreased venous blood, then there is CSF volume will be decreased. So, but the injury is like that. In some situations, now it's still growing. Let's say this SOL is becoming big and big. So it is giving lot of pressure. Now finally it has to do something because it has, everything was compromised. So what will happen to the brain when there is space occupying lesion is becoming big? So this brain will now, it will try to go out and so that it can reduce. Now CSF can be reduced by alternating the volume. Blood volume can be also calibrated. It can be also maintained by decreasing vasoconstriction, vasodilatation. But how to reduce the brain volume? How to reduce the 1400? Brain is fixed. So how it will reduce? Brain will try to go out. We call it brain herniation. Okay, we call it brain herniation. Brain herniation. So what is happening here? So there may be the brain, we know that. So there will be herniation in some part. So brain might herniate. So brain might herniate. In the last resort, it can herniate through foramen magnum here, which is called tonsillar herniation from this reason. So brain might, little bit of brain might go out, try to go out and causing herniation. That is the last resort. That is very severe because this foramen magnum is so small that brain will now distract many of the things here. Okay, it will be stuck with all the other our neurons. So brain herniation can occur in the when the intracranial pressure will go up. No, now let's summarize. When the intracranial pressure is gradually going up, there will be decreased venous blood in the brain. Next, there will be CSF production will be decreased. And third thing, when still intracranial pressure is going up and up, it can lead to brain herniation. Okay, so let's summarize these things. So this is the pathophysiology of a head injury. So let's summarize. So what happens in head injury? This is autoregulation. Cerebral blood flow is compromised. There is autoregulation is totally disturbed. And then there is increased intracranial pressure, which is normally 10. So there is increased intracranial pressure. And when the intracranial pressure rises, the cerebral perfusion pressure can decrease. So we know cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. So when intracranial pressure is increased, cerebral perfusion will decrease. As a result, it will decrease the cerebral blood flow. So as a result, there will be, when the blood flow in the brain is reduced, what will happen? There will be decreased oxygen, decreased nutrition, everything will happen. And brain will go to hypoxia. And if there is hypoxia, there will be tissue necrosis. Cells will go for necrosis due to increased lactic acid depositions, and there will be also apoptosis. And what will happen? There will be cell death, leaving a scar. And that scar might go for again production of epilepsy and many other things. So in the pathophysiology, what happens apart from that, apart from the cerebral blood flow and other things? So what happens in the pathophysiology? So when there is a head injury, there will be a tissue damage, right? So when there is tissue damage, we know what will happen. There is disturbance of the autoregulation. The whole autoregulation will be disturbed. Autoregulation is disturbed. And what else happens? Intracranial pressure will increase. So as intracranial pressure will increase, it will lead to decreased cerebral blood flow, decreased cerebral perfusion pressure. So as a result, decreased cerebral blood flow. Apart from tissue damage, what will happen? There will be edema. So how the edema occurs? In the edema, we know there is a blood-brain barrier. There is a blood-brain barrier because of the tight junctions of the endothelium. So blood cannot escape to the outside. So because of the destruction of the endothelium now, the tight junctions, so fluid is escaping here. So fluid is escaping outside and fluid is collected here. So there is collection of fluid resulting in edema. So this collection of fluid here is called vasogenic edema. Vasogenic edema. Or sometimes the cells here will get swelling because of intracellular edema. Okay, there may be water collected inside the cells and cells go big and cause edema. So it can cause also cytotoxic edema. So there will be two types of edema can occur here. So either vasogenic or cytotoxic edema. Apart from when there is a head injury, there is a process of, don't forget that that's a process of inflammation. So where there is a cell damage, here you see the permeability has increased. So there will be neutrophils coming to the situation. There will be some macrophages. There will be other things like all the inflammatory mediators like tumor necrosis factor alpha. There will be interleukin 1, interleukin 6. So these are chemical mediators which can increase the temperature and make it fever, which can give fever, which can make increase the temperature by resetting the hypothalamus and causing fever. So there can be also inflammation. Other than that, when there is all these things happening, and there can be hypoxia. So when there is hypoxia, what will happen? There will be necrosis and apoptosis. So usually first there will be necrosis and followed by apoptosis. So this is the basic scenario, the pathophysiology scenario of head injury. So to understand this, you must know what is intracranial pressure, which is normally 10. Central perfusion pressure, we know that is mean arterial pressure minus mean arterial pressure minus intracranial pressure. That is also normally 90. Okay, and then autoregulation, it's maintained between 50 to 150. So by doing vasoconstriction, vasodilatation is doing autoregulation. So overall, all these are the pathophysiology of head injury. So the brain tries to do that. That's why when you are trying to manage, so first of all, we need to control the intracranial pressure, because if there is increased intracranial pressure, it will lead to, then what will happen, in Monroe-Kelly doctrine, many things will come up. What are the consequences of increased intracranial pressure? There can be decreased venous flow, there can be decreased CSF, so there can be increased venous out, there can be decreased venous blood in the brain, there can be decreased CSF production, and there can be herniation. That thing will come out with this increased intracranial pressure. It comes as a package. Okay, when the increased cranial pressure will go high and high, it will lead to, so this intracranial pressure, high intracranial pressure will lead to what? It will lead to what happen? It will lead to decreased venous return, decreased venous blood. Then it can lead to decreased CSF, and it can lead to herniation. So this Monroe-Kelly doctrine is only up to a limit, but when the increased cranial pressure go high and high, the number remains to be fixed, and there is causing herniation. So when there is edema, now this edema is there in the pathophysiology. It will always, what it will do first, the edema when it is formed, it very quickly it compress the third nerve. So when it compress the third nerve, it will then result in dilated and fixed pupil. It will compress the third nerve. So it can be compressed by edema or whatever space occupying lesion. It is compressing the third nerve. So when the third nerve is compressed, there can be dilated and fixed pupil. Apart from that, what might happen, that there can be, because of all this edema, these cytokine markers, they will influence the vasomotor center and cause bradycardia. So decrease heart rate. So it will influence the vasomotor center and decrease the heart rate and causing bradycardia, because there is high pressure. So it is trying to, everything is trying to auto-regulate now. So decreasing the also the heart rate.